So to start with, I would like to introduce Bea Galatas. She's an epidemiologist working in the surveillance unit at the Global Malaria Program at the WHO, and she's heavily involved in the High Burden to High Impact initiative.
Okay, I'm not doing this. Back. Sorry. There you go. Hi, good afternoon, everybody. Thank you for letting me start this symposium. So I will start the symposium by explaining WHO's vision on how mathematical models can be used to inform the stratification and the prioritization of interventions in the context of the WHO High Burden to High Impact response. Which is a response that, as most of you have heard already, was triggered by the realization that the progress has stalled. The progress that we saw in the past 10 to 20 years had recently stalled, and also the realization that a lot of this recent increase was heavily driven by 10 countries that have more than 70% of the cases currently, and you can see them listed here. And these are the countries where we have started HBHI integration. So the response has 4 key principles that together aim to reaffirm the commitment and refocus their strategies in order to achieve the GTS goals for 2030. And I'm going to focus for this particular topic, and because we're talking about mathematical modeling and analysis, particularly on response element 2, which is the use of data, strategic information, to drive impact through the support to national malaria control programs to develop and implement their strategies. So I'll start by simply stating the process of how a national strategic plan is made and how it's then funded and implemented. So when we start a strategy, usually strategies aim to understand who is the population at risk, why is this population at risk, what interventions can we use to reduce or minimize this risk, when and where can we place these interventions, and finally, how can we optimize these interventions to achieve maximum impact. And this strategy ends with a set of targets or objectives that usually involve reductions in prevalence, in incidence, and in mortality. And for this process, there's many types of analytical approaches which include mathematical modeling that can be used to better inform the process, which includes impact evaluations, looking into the past and how have future past strategies work. How can we look into the future, make stratification and intervention targeting for the following strategic plan, and also make predictions to make sure our objectives are in line with strategies that we're implementing. And you will see in the following presentations from Tanzania and from Zambia how these different analyses were conducted for their particular contexts. Once we have a strategy, we usually budget it, and this budgeting process can also be improved through NSP costing that is based on modeling. Usually it includes costing at the subnational level and that allows to quantify how much money we would need to implement the full strategy. However, after resource mobilization campaigns, it is rarely the case that we have the amount of money that is required to implement the full strategy. So we have a sub amount of money or a limited amount of money to implement all the interventions, but still with this amount of money, we want to make sure that we can achieve the maximum impact with the available money. And that is what we do with prioritization, trying to ensure that the strategy, still within limited resources, reaches the maximum amount of impact. So for all of this, we need data, and that's why in the HBHI response, the first element of strategic use of information is collecting the information. And we recommend that countries present and prepare the national malaria data repositories within their HMIS systems, which currently mainly include routine data coming from the health facilities and maybe some routine intervention data or stock data. But actually, we need to include a lot more data into this repository in order to have a full idea of what's going on with malaria. And all of this data put together can allow us to trigger actions both spontaneously, but also in the long term in new strategic plans. And the rationale for these data collections and these data repositories is that we have a full story of what is going on through the transmission spectrum of a country, from infection all the way to mortality, which is driven by factors that are contextual, sociodemographic, climate determinants, vector ecology, the presence of vector control and chemoprevention, but also healthcare access and surveillance, as well as access to quality of severe case management and other causes of mortality. And all of this information together can allow us and the programs make better decisions on their future strategies. So starting with when we start looking at a new strategic plan, we first need to know what happened in the past and how can we learn from the past. That means evaluating what was the impact of the specific interventions that we deployed in the past, what was the overall impact that we achieved with the strategy that we recently implemented, but also what were the bottlenecks and the lessons learned that we can get from the previous strategy in order to inform the new strategy. And the new strategy is essentially driven by stratification, which underpins all the key decisions that we need to make both in the strategic and the operational space. For example, for the who, so who is the population at risk, we want to make sure we do epidemiological stratification. To understand the transmission determinants, we want to look into stratification of vector control, vectors itself, health systems, etc. We also want to target our interventions according to certain criteria, and we want to do all of this at the unit of analysis that is operationally feasible, but still granular enough. So I'm going to quickly go through some examples of epidemiological stratification in Cameroon, and for those who've been in the previous session, you've probably already had some spoilers from Dorothy. So in terms of epidemiological stratification, we can use case incidents from the routine data, both crude but also adjusted for certain factors such as testing rates or reporting rates. But we can also use prevalence and mortality that is at the district level through spatiotemporal analysis that can be modeled or not modeled using survey data and other sources of data from the country. And we can combine all of these factors into stratum, which can be divided into the lowest to the highest stratum according to prevalence, incidence, and mortality, in order to have an idea of where we have the largest problems in terms of endemicity overall. But we also need to understand why this is happening, why the transmission is happening. So we want to look at where the dominant vector species are, where are they, and how can we tailor vector control tools according to these maps, the same with pyrethroid resistance, and the same with access to care. So putting all those data, all those indicators together, we end up with a list of interventions or intervention mix per district that responds to a certain set of criteria per district and per intervention. And this has been the result for Cameroon. So once we have our strategy, which I just showed from Cameroon, we then need to know how much impact is that strategy going to bias? Is that bias going to actually achieve the goals that the NSP initially established? And what can we do what can we change if we haven't actually reached those goals? And mathematical models are very useful in allowing us to see different scenarios and discuss within the country what are the best scenarios that we can feasibly do in order to reach maximum impact. So that allows us to have a final national strategic plan that is then costed. And costing requires detailed costing data that is at the subnational level and is usually linked to the health accounts costing, especially when we're talking about health systems costing. And this is actually quite a challenge for this part of the analysis. And then we move on to resource mobilization, and we realize that we have a limited amount of resources to conduct our initial strategy, but we still want to make sure that we achieve maximum impact within the available resources. So we move on to prioritization, through which we need to take into consideration what does this mean, what does the fact that we have limited resources mean. It means that we probably need to scale back interventions from some areas, or maybe downscale coverage, or maybe send less commodities to specific areas, etc., etc. And these are very hard decisions, but modeling usually can help us through different scenarios. So I'm just going to give a quick example of how this criteria of NSP targeting versus prioritization works in the sense of when we talk about LLINs. So for LLIN targeting, when we're planning the strategic plan, we're mainly focusing on areas that have more than 1% prevalence in the year 2000, meaning areas that have high receptivity or have receptivity. And we also take into consideration urban areas to consider whether we're going to go for micro-stratification of LLINs or not. And that's pretty much the state at which we get when we design the NSP, is focusing on prevalence and urbanization. However, within the context of limited amount of resources, we have to go a step further and identify where we're really going to prioritize LLIN mass campaigns, focusing maybe on areas that have the highest level of transmission, lowest access to care, or lowest or highest deaths, etc., etc., and that allows us to identify the LLIN areas that really require LLIN mass campaigns. And this is actually a continuous process that needs to be done not only once, but actually every time there's new amount of resources coming in. And mathematical models are really useful in this dynamic process of reevaluating the strategy every time there's new money coming in. So I want to finish this by saying that stratification doesn't end up once we prioritize, but also within the prioritized areas, we need to make sure that we're really implementing strategies at the optimal level in order to achieve the impact that we're expecting from them. So on the right-hand side, you can see two maps from Burkina. The one on the top shows percentage of admissions due to malaria, and on the bottom, you see the percentage of deaths out of the malaria admissions. So if you realize the bottom graph identifies 3 districts that have the highest hospital malaria rates, but actually when you look in the top map, those 2 districts are not the districts that have the highest proportion of malarias, that receive the most admissions due to malaria. Therefore, there's clearly an issue there with severe case management. And it's something that we can target as well when it comes to supervision, or maybe identifying blood transfusions that need to be focused to these areas, etc. And I've included here a list of many other questions that we can also target when it comes to operationalizing our interventions, such as, for example, increasing LLIN usage, as was discussed in the previous session, and whether we could focalize our community engagement towards the areas that have lower LLIN usage. And there's many questions that we can do like that. So this is my last slide. I want to show you a quick overview of where we are at with all of the high burden to high impact country stratification status. So as you can see, most of the countries have done a very good job at providing the data and collecting the data in order to inform their strategic plans. And now we're in the process of stratification and prioritization, so that by March of next year, we can apply to the Global Fund concept note. And on the right-hand side is the mathematical groups that have been supporting the countries in order to make this happen. So thank you very much.